So I see our audience is building just as expected. We're at one pass. Okay, so let's begin. So welcome everyone. My name is Jesse Bump. I am a member of the Department of Global Health and Population, and it is my pleasure to welcome you as the moderator for today's session. And it's also my pleasure to welcome Dr. Eugene Richardson, who is our special guest today. Dr. Richardson will be presenting on his book, Epidemic Illusions on the Coloniality of Global Health. Gene is a professor in the Department of Social Medicine at the medical school. He has previously worked with Médecins Sans Frontières in West Africa and at PIH in West Africa and Médecins Sans Frontières in East Africa. So it's during his times in those assignments as a physician and anthropologist that Gene began thinking about the coloniality of global health. So it's our pleasure to invite you, Gene. We will have a brief presentation. I welcome clarifying questions if that's okay with you, Gene. And then we'll open the floor for a wide-ranging discussion. So thank you everyone for joining us and welcome, Gene.
Thanks so much, Jesse. It's a pleasure to join all of you today. And I will just exactly share some the experiences that led to the writing of this book and talk about the book a little bit, and then I look forward to the discussion. Okay, so yes, book is called Epidemic Illusions on the Coloniality of Global Public Health. And if any of you want to interact in the Twitter realm, here's my handle here. But this is basically a sum up of the book, this GIF here, that, when it comes to knowledge production, places, centers of like Harvard University, don't necessarily go after the veritas, the capital T truth, but they often impose ways of understanding social and health phenomena on other people. And these ways of interpreting the world often support elite interests. And so the goal of the book is to examine public health programs and works of quote unquote science to show the ideological work that they do. And so I have no financial relationships, although my ideology is socialist, and you'll see it come through in what I present. And so the book, as you can see from that GIF, it's kind of experimental in nature. It starts from the premise that you can't critique modernity using its terms of reference. And so it has a variety of approaches, from flash fiction to counter-hegemonic modeling to reverse ethnography to Platonic dialogues. And here, this cover is a play on Plato's Cave, which essentially it says the same thing that that GIF says, that we're used to in this Western tradition of social science or inquiry, getting to some sort of objective knowledge. And so that is represented by Plato's Cave, where there's just sort of one of these areas, and people are chained to a wall and are chained to this, and all they can see are shadows of images. And here's a coronavirus. And the idea is that the social science or social scientist or philosopher breaks from the chains, goes into the above world, and tells people, no, this is what coronavirus really is. You've just been looking at images. And so that is kind of that is it's an imperialist form of knowledge production. A pluriversal form would mean that there's the allegory is actually a warren, where rabbits live, that there are many ways of interpreting social phenomena that vie for the forefront of our consciousness. And the one that sticks is usually the one that serves elite interests, but there are actually many ways that actually have an eye towards justice. And again, that's what the book shows, how most public health science work has an eye towards reproducing relations of inequality instead of challenging them, and that there are other ways of interpreting social phenomena that actually challenge these inequities. All right. So what do I mean by coloniality? It can be described as the matrix of power relations that persistently manifest despite a former colony's achievement of nationhood. It attempts to capture the racial, political, economic, social, epistemological, linguistic, and gendered hierarchical orders imposed by European colonialism that transcended independence movements and continue to oppress in accordance with the needs of capital. Ramon Grossfugel has to say that the heterogeneous and multiple global structures put in place over 450 years did not evaporate with independence. We continue to live under the same colonial power matrix. So we were under a period of global colonialism. Now we're under a period of global coloniality. The only thing that's changed is this kind of independence of countries. Every other structure is colonized. And then Sabelo and Lovo has to say that the celebration of decolonization as a milestone in African history, Africa has not managed to free itself from epistemological colonization inscribed on the continent and its people by mission and secular schools, schools of tropical medicine, schools of public health, schools of medicine, religious denominations, and other institutions that carried Western cultural imperialism. And I've been influenced a lot by Edward Said, who wrote in Orientalism how the study, the social sciences that studied Eastern culture actually carried, Western cultural imperialism. And I endeavor to show how what we call global public health science carries Western cultural imperialism. So I'll go through real quick some of the experiences that led to the writing of the book. Here I worked for, this is before I went to medical school, I worked as a lab supervisor for a field hospital in southern Sudan. It wasn't its own country yet. This is for Doctors Without Borders. Here's the lab, here's triage, here's the wards. Here's the team. Here's where we lived, in these tukels buried underground so that the bullets wouldn't hit us. Here's the ward, nurses, bed nets, beds, patients, charts. This is where I started thinking about this double-edged sword that is humanitarian aid and then, global health. I got to be friends with some of the doctors at a military garrison nearby that were from the northern part of Sudan. And they basically said that Doctors Without Borders was part of their military strategy in the civil war against the South. They were burning people out of villages. So they were sending paramilitaries and mujahideen to burn people out of villages in central Sudan and send them south so that the Chinese could do oil exploration and then pipe it up to Port Sudan. And the people were coming to these internally displaced person camps or IDP camps, and we were taking care of them, curing malnutrition, visceral leishmaniasis, tuberculosis, malaria, and employing people. So one nurse getting $100 a month could support an extended family of 40 people with that. And so they knew this and basically said that instead of coming south and joining the Southern People's Liberation Army, which you have to really hit rock bottom to join, they're actually diverted to these displaced person camps where you support them. And so you are part of our military strategy to keep the ranks of our enemy forces from swelling. And I thought, wow, I was very naive and still am, but I didn't know that humanitarian missions could be used for, in this case, internal colonialism. But I should have known, right? If you it happened in Biafra, it happened after the Rwanda genocide across the border with DRC. And, if I had read Kwame Nkrumah, he was saying as early as the 1960s that aid is really just this small pittance that the colonizer gives with one hand to disguise violence or extraction that's occurring with the other hand. And so that's where I started to, see this double-edged sword that is humanitarianism. But as I started working more in sub-Saharan Africa and reading more, I saw that what we call public health science actually serves the same purpose, or mostly serves the same purpose. So I also worked in South Africa at a XDR-TB program, and then at the Desmond Tutu HIV Foundation in Cape Town, in the Rohingya camps, in primary care and there was a diphtheria outbreak there, and that's something we can discuss. For those of you that the idea of how social forces become embodied as pathology is a new one, it was on full display here. Here I'll compare quickly Sierra Leone and the USA, the Ebola and COVID outbreaks, just to blur these boundaries in global health. Like, what do we mean by global health? It's usually what's going on somewhere else. But if you think about what's happened in these two outbreaks, where the US now has 700,000 deaths in COVID, there really aren't firm lines between what we would call, global South, global North, or first and third world pandemic, epidemic handling. So here is this number 117 in Sierra Leone that you would call if there was a suspected Ebola case. The counterpart during COVID at the Brigham was this Biothreats pager. Last spring, there were 4 ID doctors, infectious disease doctors, with pagers handling 500 pages a day. That's how much information needed to flow. Here's the command center, a district Ebola response center that was actually set up by the British military to handle Ebola outbreak by district. And here's our command center at the Brigham. Here's an ambulance going out for an Ebola patient. We dress up in the PPE and bring them for isolation, testing, and treatment. Although there wasn't a lot of treatment going on especially initially during the Ebola outbreak in West Africa. I first started my second mission after 12 years of training, med school and residency and all that. My second mission with Doctors Without Borders was in Kailaun at a Ebola treatment unit there. Although they weren't letting us treat patients. They weren't letting us put IVs in people coming in shock, which is a crime. And 3, me and 2 other doctors got fired the first week I was there for pushing back against this. And so I quickly joined Partners in Health, whose mandate was to be aggressive about treatment. But here's a patient getting transported for testing, isolation, and treatment in Boston. Safe and dignified burials were a very important part of the Ebola containment in Sierra Leone. Here's what that looked like in the US. So there were so many people dying in New York of COVID that they had to have refrigerated trucks to stack the bodies out behind hospitals there. Here's a graveyard for Ebola patients in Sierra Leone. Here's a graveyard right outside of Manhattan. A mass grave for patients who were not claimed by family who died from COVID. Here we are doing kind of contact tracing and community sensitization with the Sierra Leone military, which actually worked very well, going house to house. That we really don't have a tracing program, contact tracing program to speak of in the US. Partners in Health worked with the Massachusetts government to start one, but that's mostly by phone, and contact tracing is not as effective in COVID because people are symptomatic or infectious up to 3 days before they're symptomatic. Here's what an Ebola treatment unit looks like, big one. Here's the Boston Convention Center for overflow COVID patients. And then this is what we were working on in Sierra Leone to decentralize the response, these small 12-bed community care centers that were built so that people could be closer to home when they were being treated. Here's a community care center in Cambridge, basically just a repurposed high school gym. All right, what changed in the DRC outbreak in 2019? Well, we have an Ebola vaccine that's very effective, although hardly anyone accepted it. And the reason they don't accept it is not because, so in the book, I have a chapter about a Harvard School of Public Health study that essentially blames the extent of that outbreak on misinformation and people's belief in sort of these WhatsApp groups and whatnot. But that actually, again, that serves neoliberal purposes. That blames outbreak dynamics on the victim and a rational choice actor, gives them a lot more agency than they really have. If you explore it, you see that there is a coloniality behind that type of interpretation. Here's another form of coloniality when those two French doctors said that we should just test BCG vaccine on Africans for COVID because they won't mask, they won't social distance, and we'll get our answers quicker. We had better diagnostics in DRC, but come COVID time, when I was seconded to the Africa CDC last year, the first thing they asked me was, can you help with getting test cartridges and personal protective equipment? I thought, oh, well, I'm an infectious disease physician and anthropologist, not a logistician, but that was the important business of the time because they had the money. They were being outmaneuvered by ex-colonial powers using their military to divert shipments of COVID supplies. So, we have coloniality in the realm of knowledge production, and I'll get to more examples of that. We have in the realm of economics, and then we have it in the realm of vaccines. And so here we are trying on a vaccine campaign for Ebola in DRC, but you can see with the current the vaccine apartheid in the COVID-19 pandemic. Another example of coloniality. It's not just that global North countries are buying up vaccines for their people, they're hoarding them. US bought 5 vaccines per capita. Canada bought 9 vaccines per capita. And not only are hundreds of thousands, millions of people going to die because of this, there's also going to be the increased variants. And so it's counterproductive on a lot of levels. Treatment did improve in the DRC outbreak. We had these new Ebola cubes, which certainly improved treatment. But where am I coming from in the book? What is my positionality? And so Frantz Fanon, in his book, The Wretched of the Earth, says that in capitalist countries, there are a multitude of moral teachers and counselors and bewilderers that separate the exploited from those in power. In the colonial countries, on the contrary, the policeman and the soldier, by their immediate presence and their frequent and direct action, maintain contact with the native and advise him by means of rifle butts and napalm. So this was in the 60s. And now that we're post-independence, the idea of the coloniality of knowledge production extends this first sentence that essentially, the book is about how public health scientists and practitioners are the new bewilderers. They're the ones that are separating those exploited in the global South from those in power in the global North. They mask the structural ways and the violent ways in which we continue to extract from former colonies. And if there's any doubt that this is happening, you can look at 2017 report from Jubilee and et al., which showed that in the continent of Africa, in the year before, there was $160 billion came in to the continent in the form of aid, loans, and remittances, and $200 billion came out in illicit financial flows, not repatriation of profit. Illegal theft of money through trade misinvoicing, tax evasion, and resource theft. So for those of you that think there is this thing called development, or we have this US AID, Agency for International Development, it's a complete farce. There's no such thing as wealthy countries of the global North that are sharing their wealth with developing countries in the global South. The continent is a net creditor to us of 40 billion plus per year. They are developing us. What Kwame Nkrumah said 60 years ago still is true, that aid is a small bit given to disguise the continued illegal theft that continues. And that's why I would say things like the Panama Papers were one of the best global health interventions of the past several years, because they're starting to lift the lid on how this extraction occurs. And so more on where this book comes from, essentially the debate on this development relationship. The current process sees the global North as sort of potential helpers or saviors to share their excess wealth. But if you see what I talked about in the on the last slide, this neo-colonial extraction that continues, and you see us as beneficiaries from a global institutional order that systematizes extraction and oppression, then we move past this failed development model, this failed humanitarian aid model, to one of reparative justice. And so I'm also a co-chair of the Lancet Commission for Reparations and Redistributive Justice. And so that means, not $10 million for an Ebola response in DRC, but the several trillion that's owed by the UK and Belgium for legacies of colonialism and imperialism. And with those trillions, there'd be no outbreak to discuss. We showed how in Sierra Leone, just money that's been stolen from diamond mining, that money alone would have been enough to build a health infrastructure that could have stopped Ebola at less than 100 cases instead of the 28,000 that we saw. So I'm really interested in the coloniality of perception. How people's world, the way they view the world is colonized. And I will admit that this is sort of using colonizing as a metaphor. And if you take Tuck and Yang from their 2012 paper on decolonization is not a metaphor, that you have to use the word decolonize to mean giving back land to indigenous people. So yes, I am guilty of using it as a metaphor, and maybe can come up with better ways of describing it. But that's the one I used in this book based on the coloniality theory, mostly developed in South America by Quijano and colleagues. But Ngugi wa Thiong'o had to say that colonialism imposed its social control through military conquest and political dictatorship. So fanals, rifle butt, and napalm. But the most important area of domination was the mental universe, the control of culture, of how people perceive themselves and their relationship to the world. So this is where the bewilderers come in. And so I represent the class of bewilderers. Harvard School of Public Health, Harvard School of Medicine, it is a bewildering institution when it comes to global health. And so the idea is, let's see if I have it here. The idea is that, as global health practitioners, that we have to start thinking not as, that we're going after this capital T truth, but rather that we struggle against forms of power where we are objects and instruments. And so instead of holding the rifle or the napalm, we actually hold the to use the metaphor, the gun of epistemic violence or symbolic violence. And this is essentially the capacity to impose the means for comprehending or adapting to the social world by presenting it in the economic and political world in disguised, take it for granted form. So again, there's a chapter, that critiques one of the Harvard School of Public Health Studies and basically describes it as committing symbolic violence. Here's another study we did that uses that approach to understand Ebola survivor well-being in Sierra Leone. So I'll leave that chapter. It also exists as a standalone article in Medicine Anthropology Theory, MAT. But I'll give a different example in a little bit about the IHME. As I mentioned, the book takes an experimental approach. Here, I exercise some détournement, which is sort of cultural hijacking in French. And they used to do this, they still do it now through magazines like Adbusters. But in the 60s, they kind of would reprogram advertisements to sort of show the ideological work that they're doing. And so I've done this with the Ebola poster that you see when, that you would see when you land in Sierra Leone, which basically serves a health purpose, right? If you're sick, go to the health center. But if you really look at this, it essentially conveys the idea that Ebola is the cause, right? Ebola is the cause of this sickness. And for me, Ebola is just a marker of all of this. And so if you really wanted to understand determinants of why people were getting sick, why there was an underdeveloped health center in the first place, then you would need to explore epistemic violence, structural adjustment, the legacy of the MAFA or Holocaust of slavery, barbaric colonialism, purposeful underdevelopment. And here's that slide I was talking about, the illicit financial flows. I also do some hegemonic modeling, which I'll leave you to explore if you're interested. So let's get to the last critique, and that's of mathematical models. So I basically see them as fables or essentially science fiction. They don't really serve as forecasts because they're almost always wrong. But they're more useful, I think, to at least the global north, because they set epistemic confines to the understanding of why some groups live sicker lives than others. These confines sustain predatory accumulation rather than challenge it. And this is the afterword of the book, but it also exists as an article in BMJ Global Health. So let's look at two examples. This first one is an article from some modelers in Proceeding of the National Academy of Science, and it's about super spreading, and they use the term super spreader 38 times in the paper. And they conclude, and this was actually picked up by the newspapers, they say this, that super spreaders drove the Ebola epidemic. They were responsible, they used the word responsible, for infecting, 20 plus people each. And this is what they mean by super spreader. This is kind of the category that is employed to describe this poor patient here. And this is what critical theorists do, right? They look at categories of thought that we use, and they don't say, do they get to a truth? Because yes, it is true that you could refer to a person like this as a super spreader if they infected 20 people and, most people only infect one or two others. But it's also true that you could refer to the mining company, the diamond mining company that stole all that money that we showed, that stole all those resources, that we showed that those resources could have stopped Ebola at less than 100 cases instead of the 28,000. But you never see anyone, using, calling the mining company a super spreader. And I think it has something to do with how causal inference is essentially a very conservative approach to understanding health phenomena. You can only really, as Miguel says, you need the well-defined intervention, and that's almost always very far up downstream, very peripheral. And so it's harder to quantify what the mining company is doing. But if you see them as a super spreader, then again, the intervention changes from this aid, this dropping the crisis caravan showing up and building Ebola treatment units, to Panama Papers type stuff, litigating against the companies and getting those resources back, taking it a step further, getting reparations for legacies of colonialism. And so the word super spreader does symbolic violence by diverting us, by narrowing the social imaginary from understanding the historical determinants, and not only understanding the historical determinants, but then also intervening on them. And so, yes, I explore epidemiology as a dispositif or apparatus, and for those of you that are interested in, this is one of my favorite articles of all time, how causal inference is essentially a conservative methodology. There's this article by Sharon Schwartz and colleagues. Also critiques of big data and regression models, but let's do a final quick jump into pandemic modeling. So Institute for Health Metrics and Evaluation have received $600 million plus from the Gates Foundation. Tim Schwab has this good article in The Nation. Is all this money distorting public health data? And I would say, based on what I just explored, of course, it's forcing a very narrow interpretation of health phenomena, one that supports monopoly capitalism and neoliberalism. Let's look at the IHME's COVID forecasts from last spring. So the true number of next day deaths fell outside of their 95%. I mean, imagine that. You can't even get it in your 95% CI 70% of the time. So they were completely wrong. But their plunging projections were used by Trump to say that he was doing a great job. So they were easily co-opted for ideological purposes. But I'd take it a step further and say that they actually do racist work, because these forecasts endorse a future where COVID disparities continue to exist. Essentially, they say, oh, we'll have 700,000 deaths if we don't do much. But if we really aggressively mask and social distance and vaccinate, we could have gotten it down to just a few 100,000 deaths. But in both cases, 2 to 3 times the number of Black people are dying, because there's no modeled risk structure intervention. There's no racial justice intervention that's put in there. And so what they do is they delimit through their exaggerated precision and acceptance of just basic interventions, our ability to imagine social alternatives. They ensure that we don't even think about, reparative action or racial justice when it comes to envisioning our future. And that's why they're a fable. That's why they're science fiction. Here, our response to it was also a fable, but the idea was to imagine social alternatives. And so one of the first ancillary papers we produced for this commission was what we thought of as anti-racist modeling, reparations for American descendants of persons enslaved in the US and their potential impact on COVID transmission. And I'll just refer you to that article. I won't go through all of it, but essentially we found that eradicating the wealth gap, which is $10 trillion between Black and white people in the US, could have reduced COVID overall by reducing R naught by 31 to 68%. And so such a restitutive program would not only decrease COVID risk among Black recipients of the wealth redistribution, it would be spread out because of the way transmission dynamics work, that it's usually the highest risk group that sets what the reproductive number is. And here's some of the mechanisms. And again, you can read the paper if you're interested. The important part for this discussion is that, once it got picked up in the news, and here's an article about it in CNN, I and the co-authors have been receiving hate mail and threats ever since. So just to kind of highlight the cultural wars that exist when it comes to interpreting health phenomena. One last bit about meta-regression, since we're talking at a school of public health. IHME does these global burden of disease studies. Essentially, this one says something like, a lot of the burden of morbidity, mortality in the global South is due to tobacco, alcohol, bad diet, hypertension. I mean, all these very downstream things, nothing about power. And so, if their stated mission is to improve the health of world populations by providing the best information on population health, to me, this is like saying that, they could have done the same for people enslaved in the US by just jumping around from plantation to plantation saying, okay, we counted up the number of people that died from, hypertension, stroke, heart attack. There you have your numbers, everyone's fine. There is no analysis of power, and therefore they do work that subverts radical interventions into racial injustice. And so, Shea Mbimbola, who is the editor-in-chief of BNJ Global Health, goes so far, and I completely agree with him, to say that it's not even ethical to publish studies like this without others that make some attempts at understanding the structural determinants instead of just this very distal stuff, which someone has referred to as being prisoners of the proximate. So to sum, we can trace human rights failings to the impoverished discursive infrastructure of objectivist epidemiology. And part of transforming global health is going to be transforming its representations such that, with an eye towards reparative justice. And with that, I will say thank you. And here's my email in case there's any thing to discuss afterwards. But now I look forward to talking with all of you.
Thank you, Gene. I'm sure we're going to have lots of questions. So just to keep an order on things, why don't we use the hand raise feature or put questions in the chat, and I'll try to keep an eye on things. So thank you very much for that wonderful presentation, Gene. I'm sure there's going to be a lot of interest in that, and perhaps even some controversy. So while we're waiting for these questions to come in, I'd just like to thank you for bringing some visibility to this issue, and start with a kind of open-ended question, which would be that, if extractive practices, if we accept that extractive practices are the best explanation for the distribution of health and wealth in the world, then it would imply that basically every institution of influence, such as our own, is on the beneficiary side. And therefore, to change things, perhaps we need to work with or within or to reduce the power of those institutions. So I'm sort of asking you, like, in an open-ended way, what is a good way forward if we accept this argument?
Yeah, I mean, that's difficult. I think if we listen to a colleague, Sir Hilary Beckles, he's on the Lancet Commission. He's a knight from Barbados. He's the vice chancellor for the University of the West Indies, and he basically says that, if you think of the 1800s as a century of abolition and the 1900s as a century of kind of this failed development and aid discourse, that maybe the 2000s could be one of reparative justice. And so, having an eye towards racial justice, anti-colonial or anti-neocolonial work in the way you choose variables, curate your facts, that like we tried to do with the anti-racist modeling paper, can be a way forward. And that's not to say, under a pragmatist notion of truth, there really is no capital T way of describing the world. There are only redescriptions, and hopefully, what we call progress is essentially descriptions that are more just as you move along. And so no doubt there will be more just redescriptions beyond what we thought of as anti-racist modeling. But essentially that is part of our goal. But let's address, if Patrick is still on here, I'm happy to discuss my characterization of their study, because there seems to be, he seems to, well, of course, doesn't agree. That, and here, you say, let's see, future events that are junior research attacked. All right, you could say they're being attacked, or I critique all the work I'm a part of too. So it's more of a critique. If you want to see it as an attack, that's okay. But here's the venue, right? We're at the School of Public Health, and we have students here to learn. So I'm happy to discuss your issues with my characterization of the study.
Patrick, if you're there, I'd invite you to offer a few comments if you like. No worries if not.
Yes, give me just 1 second to collect my thoughts, because I was, this is a busy time, so I was not able to join earlier and have not been thinking in a structured manner about these points. But this is not the first time that, yes, we are being attacked in public forum, because it is more than a critique when some of the writing becomes really personal and yeah, damaging. These are important issues, so I don't want the debate around one specific paper and the critique of a personal and close, of course, research group to come into play here and distract from the fundamental importance of what is being discussed. And these are very lively discussions, and I have many colleagues in the Congo and elsewhere who are engaging in this discussion, and it's really extremely important for us to discuss them. They are far-ranging. It's not just about publication, it's about the entire research cycle. It's about how we think about global health research. So, I think fundamentally, we all recognize that these are critical aspects. I do want to point a couple of issues, because this is not the first time we've started to engage, or at least my co-authors have tried to engage with you. But I've not, felt the need to respond to something that you never engaged us with, never contacted us, never approached us. And more importantly, I do feel the mischaracterization comes to the point where when we discussed trust, your characterization was that we place the onus on the community, as if it was the fault of the community for not trusting responders, which is actually the exact opposite of our message. There are many reasons, the colonial past being one of them, but many other factors that affect whether you are deserving trust. And our work with the peacekeepers, especially in the DRC, is a critical example of that, of an organization that is not meeting its expectation, its mandate, and as a result does not earn the trust of the people, and as a result cannot do its work. And so you are in a vicious cycle because fundamentally you are not engaging, you are not understanding and assessing people's perspective, you are not trying to understand and gain that trust. And the same can be said of the Ebola response. And these, again, I feel a little trapped because I've not had the time to really formally think through what remarks would look like. But the point was exactly that, which is that it is not the community's responsibility. It is the fact that for 30 years, there has been international humanitarian presence in the Congo, and they have failed the people of the Congo. And when we talk about how that then impacts the response to the Ebola outbreak, it is clear that it is not the community that is at fault here, but the international humanitarian responses. Now, in 3,000 words in a single paper, it's hard to convey. But if you had asked us, we could have told you and shared with you all of the engagement that has been done with Ebola responders. We could have discussed with you how over the last 10 years, we have worked with literally hundreds of researchers and trying to build capacity, trying to work and support local research, including through grants for local researchers to conduct their own research, in which we just serve as advisory. So the point I'm trying to make here is that you should carefully consider the damages that you can do as well in those discussions and in the type of accusations that you are making, and frankly, not adopt some of the behaviors that you are critiquing. I feel very strongly, and this is the first time I'm doing this in a public forum, and I apologize for the people attending this event, because I think, like I said, I don't want to distract from an important academic, intellectual, but also practical debate around decolonizing research in global health and in public health. But at the same time, I do feel that when you're on the receiving end of criticism, which can be fair, and I have received fair criticism and I can certainly take them, it's one point, but when it becomes personal, as I said, and full of mischaracterization, I feel quite strongly. I'll stop here. Again, I apologize because of not having prepared and not having been aware and engaging on today's presentation. But I think at some point I would love for us to have a forum and have a public debate, but this is not the place. Thank you very much.
Thanks. You know, there had been correspondence back and forth with your team, and I said I'm totally happy to set up an event to discuss these things, and nothing came out of that. But you know, here we can continue.
No, I will not let you say that, because these were after you published papers on this
Sure.
issue. These were my colleagues trying to reach out to try to understand why you were doing those accusations and publishing well before you had any discussion with any of my colleagues. Again, I do not want to distract, but do not make statements that are incorrect. Thank you.
So again, I will say the truth that yes, I was contacted after these publications came out, and I said, I'm happy to just set up, and I'll forward the email to the whole group if you want. Happy to discuss these things in a forum like we can do now. And again, nothing came out of that. So, and this is after the publications came out, and I'll totally stand by them, because I've worked in Africa for 20 years, like you have or more, and my colleagues there have encouraged me to publish something like this because they say they wouldn't dare do it, that it needs somebody to weaponize their privilege to talk about this type of global health, practice. One, I think we're getting to the point where global health research, conducting it without a clinical delivery platform, to me is unethical. And so there's no clinical delivery platform with anything that's being done with this work. So, there's one issue there that's separate from any of the accusations, as you say, I've made them. But you're still fetishizing this humanitarian, the UN Army, which of course has done a horrific job, but the UN is a colonial construction. WHO, there was only 2 African countries at its forming. So it's part of the neo-colonial apparatus. To not keep walking that back to the colonial determinants, again, shields them. And so it doesn't, I don't think I characterized the idea is that the analysis is too proximal. And by being too proximal, by even blaming it on a failed UN Army, again, disguising what reparative justice could do. And I fully stand by that this, studies like this will be on the wrong side of history. And the reason I chose the Harvard School of Public Health study is because I'm part of Harvard. I could have critiqued anything, but I'm going to critique my own institution. You'll see previously when I was at Stanford, I critique studies from there because I don't want to make it look like I'm just, standing in the self-righteous position. Like George Orwell, who realized he was part of the imperial apparatus by holding the rifle when he was in the Burmese army, I realize I'm part of the neo-colonial apparatus because I hold the epistemic gun. And I don't think your team recognizes that. And so that is where the critique comes from. I'm just as critical of myself and outfits I'm involved with, including Harvard Medical School. And so I'd be happy to do a much, longer discussion where we can actually get at this because, this
is exactly the problem. You just said you don't think my team realizes that, and yet you have never talked to any of us. And
I just see your publications. It doesn't matter, but I don't need to talk to you in the background. What Foucault said is people know what they do. You know what you do. You're a great public health scientist. They know, why you do what you do. You want to help people, but oftentimes you don't know what you do does, how your work that's published in the Lancet Infectious Diseases continues this reproduction of transnational relations of inequality. And I'll stick by that critique.
So I'd like to propose that we move on from this specific back and forth. And I'll say that I don't know whether the department will be interested to organize something. There might be, but certainly I, within the Talk to Me program, am happy to organize a public discussion around the practice of public health and epistemic violence and colonialism. So I look forward to continuing that specific discussion and related ones in a different forum. But I will follow up with both of you. I'll check with the department and we'll see how we can take that debate forward. So thank you for getting us going and thank you for participating, Patrick. We got a couple of hands up, Leonard and then Mel. Why don't we take 2 questions and then you can respond. Okay, Gene? Great, Leonard, please go ahead.
Yeah, thanks a lot for giving me the opportunity to join this talk. And I think it's irrespective of the, like the spiritual back and forth, I think it shows also once more like how much more discussion is needed on this topic. Just one, so I think one essential step is definitely this awareness building, becoming aware that there are these colonial traces in much of the work we do and the way we cooperate with research partners. But I feel in this debate, often we lack a little bit the perspective of finding solutions. And of course, awareness is important. Building solutions is always harder, I guess, than finding out about the problem. Yeah, maybe a question to you, Professor Richardson. Are you aware of any best practices or would have other research projects in mind that worked out better? And maybe that's also something to think about, maybe also in a, and then I'm also wrapping up, in a more long-term step to have a forum to discuss on the issues, but then the long-term think about more about creating a dialogue for finding solutions and also having it from a partner center. perspective rather than from a global north privileged perspective that, yeah, I'm also part of, unfortunately.
Thank you, Leonard. Mel, do you want to go now?
Oh, hi there. Can you hear me? I'm currently walking to my lecture, sorry. So thank you very much, Dr. Richardson. I really enjoyed your presentation. I just wondered, so you referenced the writings of Frantz Fanon and Nkrumah during your presentation. And I just wondered how applicable what they wrote and their ideology is to the modern day situation, and how you think things have evolved since the 60s. Do you think that things have improved, or, you know, is what they've written more applicable now than ever?
Yeah, thanks so much. I'll start with that one. I mean, yes, I think it's more applicable than ever because it hasn't improved at all. It's just switched. So, you know, where he talked about they had the baton and the napalm and they were in country. So that's what decolonization did. It moved them out of the country, but changed that type of imperialist approach to one that deals in economic extraction, epistemological violence, Panama Papers kind of stuff. And so I feel like, and I say this in the book, right? None of these ideas are novel. I'm almost trying to translate them for modern public health practitioners because no one seems to have gotten their insights. And this kind of leads into Leonard's question. Shea Ambibola has also written a paper, "Will Global Health Survive its Decolonization?" And the answer from them is probably no. I mean, it's a ridiculous idea that that this type of aid would need to continue if legacies had been repaired, right? If they're if we don't keep whitewashing this extraction and instead move to a reparative model where everything that was stolen gets tallied up and paid, which is essentially what we're doing with the Lancet Commission, then we're not even going to have this thing, global health to speak of. There's not going to be that Ebola outbreak for us to even go study whether it's misinformation or the army or colonial legacies that are determining it. And so that's my point. Anything that doesn't get to, and this is Fanon's point, right? There's not, like, anybody that's doing this incremental stuff, there's no such thing as like a gray area to get to decolonization. It's very Manichaean. It's either or. You work towards total decolonization, or you're part of the mechanism that continues to reproduce it. And so, yes, I think that it's even more apropos now, and I'm hoping that we can incorporate it. And part of the reason we can is because no one will fund it, right? No one's going to get funding to do this type of study. They're going to get the funding to study the proximal determinants and what interviews tell you and all that kind of stuff. So part of the reason that that we continue this approach is because of funding, and the other is because of how we're programmed as public health practitioners. And that's why I think that debate, was very good for students here to really see maybe hyperbolized sides of the debate, but to see that, so where you might be able to go in your career, how you want to move the needle in public health.
Thank you, Gene. I think, the passion that we see here speaks to the importance of the topic. And I'll ask you a question that I've been wrestling with. And one of these is that some people have pointed to benefits of colonialism, if you will. Some people have pointed to things that they think are positive. And to me, as a historian, I look at the scale as the determinant of that answer. So at the largest scale, I think it's pretty obvious, at least to me, that it's an incredibly destructive and negative process. And then if you look at a really fine scale, well, sure, it's probably possible to find a couple of things that were good here and there. And many of the tools that we use in global health are in that really small miniature scale level that's not able to account for wide scale phenomena like colonialism or slavery or oppression or racism or even resource contracts. And given that all of our capacities as a field are in that latter area, how would you use any of these things that we're doing, like the mainstream, not the book that you've written, but how would you use the mainstream to try to address the problems that you identify?
Right. I mean, that's one of the biggest critiques of Marx, that he said, you know, colonialism was a boon for places like India because it helped him get to yada, yada, yada. I would say in response to that, you know, don't even bother with my book. Just read Wretched of the Earth by Frantz Fanon. If there's any illusion about, you know, even 0.1% of colonialism being a positive thing in the world. To move on what we can do today, I mean, so yeah, we have epidemiology has done great things, you know, tobacco causes cancer, masks prevent infection. You know, we learn a lot of ways to protect our health. But, you know, when that gets translated to say, we've developed an mRNA vaccine for COVID that is then not shared and IP is guarded so that big pharma can continue its profits, and that and the result being that millions of people will die because they don't get the vaccine that could have been ramped up a year ago, then you see that how again this sort of coloniality infuses the benefits of public health science, which, you know, people can have said that vaccines were the greatest invention of humankind. Well, they're not when they're hoarded in a way that that allows, you know, companies to profit over people's lives. And the thing is, it's not even like they developed all the technology for it. A lot of that was publicly developed. A lot of the resources came from the extraction we're talking about as legacy. So if you walk things back and understand things historically, then there's no ethical justification for, and I'm just continuing to use the example of vaccine apartheid, but that's what we got to work against. You know, once we do get the tools, once we do get the boons of our public health work, how can those be used to achieve health equity?
That's fair. That's fair. I think that dovetails neatly with a question we have in the chat from Christine Amuta. I have to warn, we're at 1:57. We have instructions to stop precisely at 2. So we'll need a prompt answer, Jean, but she has asked, how do we translate decolonization into roles that are often very circumscribed?
Yeah, I mean, that's one that's hard for me to answer. I actually don't use the word decolonize, but twice in the entire book because of my position, right? I'm not the one, you know, I don't experience what it's like to be on that side, you know, of neocolonial oppression. And so I don't have the answers for the response to it. What I think I do is like George Orwell, like as the holder of the gun, I report on what me and the army I'm a part of do. And hopefully with that information, hopefully that gives, you know, data or experience, or hopefully it helps as an ally to, you know, decolonizing approaches. But for that, I guess I would, you know, refer you to people like Madhu Pai and Sheye Ambibola, who are, you know, working on and have published actual, you know, ways of intervening. I mean, I would stick to reparative justice, like I've been talking about. But again, I'm just a convener for this Lancet Commission. Every section is written by people that would benefit from the reparative scheme that they're writing about. So I can, you know, I guess I'll refer you to some other scholars to help answer that.
Excellent. Well, thank you very much, Jean. This brings us to our time. I'm very grateful for you sharing your energies, your book, and your time with us. I appreciate this. I will follow up on separate debates, and we will take it from there. So thank you, everyone, for joining. This session is now closed.